We're live. Hi, I'm Ralph Preston. I run Stroke Buddies, and every Tuesday we have these recovery and science Zoom meetings where we try and bring you some useful information for your recovery. And today we're going to talk a little bit about Myomo, a upper extremity device, and we have Dr. Anthea Dsouza, who's a physical therapist, doctor of physical therapy with us, and she's going to do a little presentation, and then we're going to have Q&A. If you have a question during the presentation, feel free to unmute yourself. We'd like people to mute themselves if they've got like partners not paying attention, dogs that bark at the UPS man, things like that. So feel free to ask a question at any time other than interrupting. And so, Dr. Dsouza, without further ado, I'll turn it over to you. And I want to thank you for taking time out of your schedule to share this information with us. So,
Absolutely. Thank you so much, Ralph. Thank you for having me over. I'm excited to be here, and thank you all for making time today. So yeah, a little bit about me just to introduce myself. My name is Anthea Dsouza. I am a physical therapist by profession. I was born in Dubai and raised in India. That's where I've been practicing PT for a couple of years. And I've also practiced as a clinician here in the United States for about 7 years now. And I am currently a clinical specialist for Myomo. And Myomo is the company that we're going to talk about today and the product that it makes to help our stroke survivors. So that is the point of our discussion today. So I do have a brief presentation, which I can just jump into. And then we can, like Ralph said, at any point, if there are questions, feel free to just stop and we can discuss, as opposed to keeping it, towards the end. But all right, cool. So can y'all see my screen with the perfect, beautiful. All righty. So Myomo, I'm not sure if y'all have heard of Myomo before, but Myomo is the company. It stands for My Own Motion, and we make what's called the MyoPro. So our device is called the MyoPro. And just a little bit about the company real quick. We're based out of Burlington, Massachusetts. That's where the headquarters are. It was started in 2007 by a group of really smart engineers that came up with the concept. They've used myoelectric technology and incorporated it into an orthosis or an arm brace. And that is essentially how it came about. It is FDA approved. It's been in use for a couple of years now. And the mission of Myomo is to develop unique tools to address our upper extremity issues. So it is a device that caters to weak upper limbs. So yeah, and this is what the Myomo looks like. The MyoPro is a custom-made myoelectric orthosis, and we'll go over what myoelectric technology means, but just to briefly summarize, and I think you all have heard this before, but myoelectric activity is essentially little electric potentials that are generated in your muscles. And most of the times post-stroke or in a weak upper extremity, there's still some residual myoelectric currents there. So we use that, and we'll go over what the technology essentially is. But when I say myoelectric, that's what I'm talking about, the little electric impulses that you have in your limb. So our device is custom made to exactly fit an individual's measurements. we use surface EMG sensors. So that's the cool thing about the device. We have little sensors that are placed on different locations of the different muscle groups that we target. So it's different than your traditional e-stim, which I'm sure y'all all have used at some point, which is external stimulation, correct? Like given to the muscle, but we don't give anything to the muscles here. We're pretty much listening and taking and using that for movement. And then the brace consists of, or the exoskeleton is what you see in front of you. So it's made of different 3D printed, parts that incorporates our sensors and the two motors, which is the robotic part of it that assists with movement. So yeah, that's pretty much what the product is. Now I know that currently in upper extremity rehab, there's a bunch of things out there that y'all have probably heard of before. We have the rehab robotics like the Myomo, there's the Bioness, which is your e-stim, stimulation. Everybody at some point goes through strengthening and exercise. There's the passive active range of motion. And then this is what we see in traditional therapy, correct? After a stroke. And it could be for the upper limb, the lower limb, whatever, but for today, the topic of discussion is upper. But how the MyoPro is different than the rest is because it offers functional assistance. So essentially, you're using the brace to perform or to help with a functional task that requires you to move your elbow, that requires you to move your hand. And there's long-term rehab potential with it, correct? So that's kind of what makes us a little different. And then this is just a summary. I'm going to play this video. I hope it catches yeah, you can hear, right?
The MyoPro represents a cutting-edge technology combining decades of experience in prosthetics neurorehabilitation. The MyoPro is the first brace that can read and utilize a person's muscle signals in their arm to improve arm and hand function. The MyoPro is driven by the electrical EMG signals that muscles naturally give off when they're active. Those EMG signals can be picked up directly from the skin surface by the sensors. The sensors do not provide electrical stimulation to the muscles. They simply sit on the skin and act like microphones, listening for the EMG signal naturally generated by the muscles. The MyoPro can benefit people affected by stroke, brachial plexus injuries, spinal cord injury, brain injury, and other neurological conditions that impact upper extremity strength. When the muscle is active, it will generate an EMG signal, which is picked up by the sensors. Once the signal is strong enough, it will trigger the motors to engage and move the elbow and hand. This completes a feedback loop, which strengthens the connection between brain and muscle. The MyoPro acts as housing for these sensors and provides a supportive brace for the arm. When you put the MyoPro on your arm, the 4 sensors inside will line up over specific muscle groups. When it is powered on, those sensors simply listen for the EMG signal from those specific muscle groups that it's time to bend or straighten the elbow or open or close the hand. The EMG signals pass through a software program that can amplify weak signals if needed. When the EMG signals are amplified enough to reach a threshold point in the software, small motors on board the MyoPro are activated to move the user's arm and hand. This allows the MyoPro to provide motorized assistance to move the weakened arm and hand at the user's initiation. The user is always in control of their own hand and arm as the MyoPro is responding to them. Learning to operate the MyoPro takes practice. Because the weakened or paralyzed muscles may have been dormant for a long period of time, it can take some time to learn how to activate your muscles in a coordinated and efficient way and generate functional movement in the MyoPro. Myomo strongly encourages all users to work with an occupational or physical therapist as they begin to learn how to use their MyoPro.
Yeah, so that is pretty much, that kind of touches on what the device is and how it helps. So yeah, we'll go over the specifics, the details of it. But again, at any point, if there are questions, feel free to stop and ask. So neuroplasticity. So we're going over this slide because this is pretty much the whole point, the crux of our device. And this is not novel to a lot of you because this is how we retrain our brains to, perform movements again. So just to go over this slide, our brain rewires itself after a stroke or an injury, correct? We're always learning new things. The more we're practicing a task, with more repetitions, there's new pathways formed. And why this is important for the MyoPro is because of exactly that. We're retraining our mind. We're using our brain to send signals to our muscles that have been dormant for so long. And the assistance of the device when the motors kick in is kind of what gives you movement. So it helps retrain your body, your brain, and your body to make these new pathways. So not only are we're using neuroplasticity, we're also in therapy to kind of engage with that part of it. And then with your repetitions, with you using the device at home, you are building up to the point where you are hopefully using your arm like you've never used it before after the stroke, correct? For whatever functional tasks, to do things around the house, to use your hand again for various things that you'd like to do. So that is essentially the foundation of what we use it for. So again, just to go over our little sensors, which I don't know if you can see, but this is what our sensors look like, and they are pretty much embedded in the device, right? So our sensors sit on different muscle groups, and they act like little listeners. They listen to whatever your muscle is telling them. So they pick up on that activity, they translate that into code and translate it into our motors. And then when our motors kick in, that's when you have movement. So this video right here is a little depiction of, of how it works. So when you activate or facilitate a contraction, which means, let's say you're attempting to bend your elbow, you're attempting to bend, the sensor that sits on your biceps is now picking up the information, translating it into our software, which is embedded, and we'll talk about it. And that software allows for your therapist to kind of manipulate, your movement. So let's say you have a weak bicep, there's no movement at all. We can increase the sensitivity of the sensor sitting on your bicep so that there's much easier attempt to move your bicep through the range of motion. So if that makes sense. So our software is pretty cool, especially for our therapists to kind of make it easier for movement, kind of make it more challenging, depending on what the task or goal is. But yeah, that's pretty much how it works. So every time you're attempting to bend, it kind of hits that threshold and triggers the motor, which causes the rest of the movement to occur. So you are putting some effort into movement, but the machine is also kind of assisting to complete that movement for you. If
Sorry for
that
real
makes
quick.
sense.
So you have to have activation to use
Yes,
this product?
that's a good question. You have to have what we call, so even if there's a flicker or a contraction, that's a good place to be. However, even if there's no active contraction where you cannot see it, but there's a detectable EMG, which we screen. We will evaluate to see how much activity you have. But there is some residual activity that needs to be there in order for the machine to work. So does that answer your question?
Yeah, it does. How do you guys determine if there's any activation at all?
Yeah, and that's
How do
why
you guys measure that?
we come in and we do what's called an evaluation where we put little sensors on you. We have a mark unit. We put it on you and we look at our your EMGs to see if there's anything there or not. And there is a minimum requirement. So you have to have a detectable EMG in, the two joints. For most part, there's one, but everybody presents differently. But we do that. We evaluate to see if there's anything there.
Okay,
Yep.
thank you. Yeah.
Yeah,
Is, is there an issue with when you put it on, making sure the sensors hit you in the right place?
Yeah, no, that's a good question. So it is specifically designed so that you can take the sensor off and relocate it to where. Yes. So it's not often, but I will see therapists or even users take it out and put it right where the bulk of the belly, where you get most movement. So you can relocate and reposition your sensors.
Right, because a 6'3" man is going to have a different length arm than a 5-foot woman.
This is true. Yep. Also, to remember, the 6-foot man will have his own device catered and tailor-made for him. So it is custom made for him. So what he uses, yes,
That's an important point that I didn't know. So I guess I'm glad I asked. So each one is essentially fitted to the person size of their arm.
yes, and that is an important, and thanks for bringing it up because, yeah, so if it's something catered to you and tailor-made for you, not nobody else can use it. So that is kind of why we, evaluate, we screen, we take measurements, and we configure it to your specifications, and then it's yours to keep for life, right?
Thanks.
You're welcome.
Yeah, that is important.
Mm-hmm. Yeah, so here are a couple of videos to show you just what it's like without the MyoPro versus with it on. This is our guy who's attempting to bend his elbow.
Go up. And then try and lift your arm straight out in front of you.
And then this is with the device.
Do a couple repetitions.
As you can see, there's a full range of motion, which allows for more ability to do a task that needs that kind of range, right? So because of the range of motion he achieves having the device on, this is what he can do using the affected arm.
A lot more motion.
Now, for someone that hasn't moved their arm and bent their elbow, that's pretty impressive, right? To pick something up, put it down using both arms.
Go up.
So,
Go ahead and do a couple repetitions.
all right. I guess this is another video to just show you what the range of motion looks like in the biceps. Okay, now who are candidates? And I'll just go over this real quick. This is important to know. So anyone with a neurological impairment, so stroke is, for most part, this is a major chunk of our population, but it can be other diagnoses too, like brachial plexus injury, traumatic brain injury, spinal cord injury, essentially anyone that has a weak upper extremity, right? The inability to use their elbow and hand. Intact cognition is a big one because you need to know how to contract, how to relax. You're not expected to learn the details of the technology, but enough for you to be able to have and develop control. We talked about the EMGs, one EMG signal per joint which essentially, again, we screen and we find that out for you. So grossly normal passive range of motion. This is an important one because for someone that has had a stroke years ago and has not moved, we tend to see a lot of the hand flexion hand contractures, correct? So it is important that we have passive range of motion. If they're not able to don it and put their hand in the device, it kind of defeats the purpose of it. So so it is important that they have at least the ability to stretch it out. So full passive range of motion is nice to have. Spasticity is a big question that we get. So moderate spasticity is okay, because again, we can use it for reduction in tone. However, if it's an extremely spastic limb or it's rigid, then that might not be the best candidate. The arm must fit within stated body dimensions, which I will go over. If it's a really big arm, we 3D print our parts, but there are specifications. And then a highly motivated person, it always helps to, we want someone who's really encouraged, motivated to put it on every day, do the work to get to their goals. And we have a few independent users, but we also, it's nice to have, caregiver support, initially at least, but um, yeah. And these are the contraindications or bad candidates, right? So it's pretty much the opposite of what we talked about. So if there's insufficient EMGs or nothing at all, then that's not going to work. If there's extreme pain, like your shoulder pain syndromes or hypersensitivity, extreme tender to touch, that's not going to work because you are actively moving every day. Subluxations or dislocations of shoulders. Subluxations are not uncommon to see post-stroke. So about 2-finger, width is okay. Anything more than that, again, we screen everyone and we kind of decide and gauge if you are a candidate or not. So and then severe tightness or spasticity, like I said, if it's an extremely contracted arm and there's absolutely no range of motion passively, then that might not be the best candidate. Someone that's completely, has suffered some cognitive impairments, it's hard. It's hard for them to gauge, understand, and there's only so much a caregiver can help and do. So those are not our best candidates. And then other things like we talked about sizing. If it's a really big arm, we might have to look into that. If there are active contractures, probably not your best bet. And then missing bony joints. So this is an orthotic for people that have their entire limb intact, but not amputees, right? So amputees have their own prosthetics, which is different. So yeah, any questions so far?
What's the screening process look like? Like, do you work with an OT or do you actually come out to the customers?
Yeah, no,
How
that's
does
a
that,
good question.
what's that look like? Yeah.
Yeah, so once we get, we usually have like a pre-screen call where we'll ask you pretty much these questions. And then if your insurance covers it, if it looks like, yes, you will benefit, we'll come over to you physically in person and do the screen. We have clinical specialists like myself. We have like CPOs, so orthotists, prosthetists that pretty much do the fitting of the device. So it's either them or us. The clinical team comes out to you and does the evaluation. Yep. So,
Sorry, can I ask you a question? I tried a couple of times to get this product, and I was told that there was no one in my area and it had to be covered by insurance. And so as hard as I tried, I couldn't get it. And I fit all those things. I can move my arm. I don't have high spasticity. I have a wonderful caregiver, my husband. I had everything and I was declined. It really upset me because I wanted this very badly.
Was it the insurance that stopped you, or
Yeah, I said I would pay for it, but they said that they work only through insurance.
okay? Was this how long ago was this, Nita?
A year ago?
Okay. We'll touch base after this and look into it. But I'm sorry that was the case. I wonder if, yeah, insurance is always, I guess, our hardest. And we'll go over that too, like what insurances cover it. But if your insurance will pay for it, there's no reason. There's also pocket people that will pay for it upfront, but it is an expensive device, right? It's about $65,000 to $68,000, which is
What?
yep, that's how it is. However, there are if it's out of pocket, that number is adjusted, but for most part, our Medicare covers it 100%. Yes, Ralph.
You used to have a rental program. Is that still in place?
So I don't know about if we have that. I will have to double check, but at this point, I think it's usually get the device, custom make it, give it to them. We have mark units, but that's more for diagnostic purposes. But I do not believe we have rental units to give out. No, but I will confirm that with you and get back to you.
Okay, well, we can put it in the description under the video. It's something people want to know because most people are, not everybody's on Medicare and not everybody insurance cooperates all the time. While we're on this, one more thing is it's my understanding it's available in the U.S. only at this point. Nita, are you in the U.S.?
I'm in the US, but you have to have a clinician or somebody that can assess you or help you. There were two reasons why they wouldn't let me have it. And one was they weren't even prepared to talk to me unless I could get my insurance to pay for it. And I have a high deductible. So I said I would pay for it out of pocket. And the second thing was that they said in my area, Cincinnati, Ohio, there wasn't somebody that I could get to come out and help me. That was a year ago. I don't know if it's changed.
I would think that's changed because Cincinnati's, top 20 or 30 city in the country.
Exactly. I was very upset about this because I was so excited about this when I found it.
Well, Dr. Dsouza said she'd follow up with you.
Yes, Nida, I would like to get in touch with you because I know for a fact we have a specialist right there in Cincinnati, in Ohio. So you should get that. However, if it's an insurance issue, then we'll have to look into it. So we'll talk. We'll talk after this. But in terms of a screening, someone will come over and screen you should you qualify for it. Yep.
Thank you.
You're welcome. So, okay, so I have to mention this. Now the MyoPro has a wrist. We have two devices. One is for the elbow and the hand, which is our most common one. But we also have what's the Motion W, which is solely for elbows. So if there's someone that has better function with the hand, they don't need the hand as much, but they definitely need an elbow. We have that too. It's a little uncommon. This one, which is the MyoPro 2X, is our most commonly used one because everybody wants to get back their hand function for most part. So it does have what's called the 3-jaw chuck, which is essentially this movement. So it allows for this grasp. So the hand is this, and the elbow is your full biceps flexion and triceps extension. So some of the features real quick, there's the battery that comes with it, which is rechargeable. The weight of the device is about 3.5 pounds, which is a lot lighter than what it used to be, but they're still working on the design. And there's a 3-year warranty. Myomo is very good with supporting our, like should anything go wrong with the hard the hard goods or the soft goods, Myomo will just send it back to headquarters, fix it, and they're pretty good with that. And then it has our accessible interface, which is we'll go over our software, which is right here. So the cool thing, yes, Ralph, sorry.
I was just going to say, can you get a second battery so you can be charging one and while you're using up the one battery, charge the other, I would assume.
Yeah, that's a good question. We have been having two batteries. I don't know what the status is right now, if they're still sending two out, or the expectation is just to have the one and recharge. But the recharging time is pretty, I think it's less than 2 or 3 hours and you're good to go. You're also not using the device all through the day, right? You'll maybe spend 30 minutes to an hour and then you can swap. The battery lasts for like between 4 to 6 hours, depending on how much you use it again. So, but
Okay.
yeah.
That would have been my next question. How much during the day are you supposed to be wearing it? So you're actually using it for some functional activities, but I would assume part of the deal would also be to do some targeted exercises so that you would work on building up the connections.
Pathways. Yeah, no, this is a good question. Yes. So you're using the brace for whatever you want it to be. If it's functional based, you're putting it on, practicing your functional tasks. However, if you're using it more for remedial, you want, your therapist says, okay, home exercise program is to get 50 reps in of each mode, then you're doing that and you're working solely on your therapeutic part. But either way, you're not having the brace on for hours of the day. It's a functional, you use it for what you need and then you put it away, right? It's not like your traditional or your splint. There's no other use than for function and therapy. So we've not had like battery issues. People will just charge and then they're good to go. It's like charging your phone.
Everything works better if you do it in coordination with targeted exercises. And of course, the big question is, well, official terms carryover. You want to build up carryover to where your arm starts working better without the device. So, what can you tell us about carryover?
Yep. So I have a slide on that, but
Okay, sorry.
thanks for that question. Hold that thought. It will come up. But real quick, the MyConfig software, this is my favorite part because as a therapist, it's so cool how you can manipulate the device to what your specifications are. So let's say I have a user and we are solely trying to focus on getting him to move his biceps. So as a therapist, I will kind of play around with the settings to where he has active control now. Let's say he's doing this for whatever, however long it takes him to get to the point where he's better at doing that. And now I can take it down a notch because he's gotten some strength back. So I will reduce the gain. So essentially, long story short, it's nice to have these parameters that you can control using the software. So therapists like this, they like to play around with it for outcomes. And this can also be learned by the user itself. It's really whoever wants to take the effort to learn more about it, but the therapists are expected to know this, and we help with that. We offer a pretty intense. We offer like a training program for therapists around or whoever you work with.
Oh, so that would be like your local physical therapist after you get the device?
So it works. We have MyoPro trained therapists all over the country, but if you work with a specific therapist that you like, we just get them trained if they're open to it. And the training is not hard at all. It's like a module. It's a course they can take online, and we offer CUs. So it's always we have therapists that show interest in taking and learning the program. But if you wanted a specifically MyoPro trained therapist, then we can provide you with that information too. So it's good to have a therapist, at least when you're initiating, when you get a MyoPro device, we strongly encourage you so that you know what you're doing, you have an agenda, you're on it. And then it's up to you and the therapist. Once you meet your goals, once the therapist feels like you don't need me anymore, then you take the device home and you're on your own for long-term, use.
Can you share some information on how the device actually affects the brain? Or it stimulates the arm, but once the device is turned off, you're back where you started from. Where's the connection of the arm and the hand movement and what's going on in the brain?
Right. So that's what I think Ralph's question was also kind of similar grounds, where is this more like compensatory or is this remedial? In the brain, when you're teaching your brain to activate, like newer signals are being formed because you're actively attempting. The more reps you're doing, you're training, your brain to perform those movements over and over again. So the goal and the hope is to have those new pathways formed to the point where you probably don't need the device. However, there's no promises made here because everyone presents differently. Everybody's, presentation is different. So if someone were not able to get those formed again, then they can use it for solely compensation. So they're using the device to help with function. But I don't know how to answer like how much you will get back, or how many more, like how soon it will take, or everybody's different. We'll have people who pick it up instantly. That's just higher functioning. They're using it to the point where they don't really need it anymore. But there's people that take time. There's some that really have to work up to the point of getting to do a task and function, and that's okay too. But to say that you put it on and the robot does things for you is not right. That's not how it works. You have to put in effort every day, consistently, stick to your home exercise program, have a good therapist for really true, to get the efficiency of the device, if that makes sense.
What was the clinical trials they did? What was the outcome?
That's a good question, Nita. We have about, I want to say, between 6 to 9 research publications, and they're all on our website, which Ralph will share with you. But essentially, there were good outcomes with how therapists have different tests that they do, like the Fugl-Meyer test or your DASH scores. They'll take scores before, and then they'll take scores after using the device, right? So there have been good outcomes, but I would encourage you to read through them, because I don't even remember, the specifics of each. There's like 9 of them, but I would look at our clinical studies, because this is evidence-based. This is not just something we're throwing out there, right? So yeah. I will share that link with you. I think Ralph is going to share our website so you can look at our publications.
Yeah, I'll put all of her contact information, any links that you give me, Dr. Dsouza, the answer to any questions, I'll put it all underneath the video in the description.
Perfect. Yes, thank you. And that way, feel free to call me get in touch with me. My email will be there. So just call. Any questions, just call and I'll be happy to answer. Okay, I'm going to skim through this real quick so we have more time for our Q&A. But every device does come with a harness for, shoulder support, just to pick up some slack. Every device also comes with a laptop. So these are just to summarize the key features. It is a custom fabricated myoelectric orthosis. We are encouraging functional tasks. We are encouraging repetitions of your affected arm. So you know how you stop using the affected side, you're using only the dominant side? No, we're encouraging more reps and use of the impaired arm. Neuromuscular retraining, which we went over. The benefits of long-term use. Now, this is your device to keep, so this can be your therapy at home for as long as you want to use it. It's non-invasive. It's not like eStim, so there's no electric stimulation, and it's portable. So this is the slide that I was talking about, compensation versus remediation. And this is a common question we get, right? Will I get my strength back? Will I get my function back using the device? That's not a claim that we make. However, we encourage you to use it, and the hope is that you gain some function back. If not, it is still a functional device. So you can put the device on, and then the hope is that you use it to do your functional tasks. So it can be either or, it can be both.
So I could bring it to the gym and do some curls.
You can do whatever you want with it, but there's certain restrictions. Like I wouldn't drive with it. I'm pretty sure that's not encouraged. But yes, you can put it on. I have a client he takes it to Publix and he'll grab his little chips and put it in his cart. So he has worked to that point where he can use it to extend,
Like
grasp.
take things off a shelf, put it in the cart.
Yeah.
You know, hold a weight and do a curl. Because how do you strengthen a muscle without that movement?
Yes, this is true. And if bicep strengthening was a goal, then there's a way to encourage that too, right? With the software. But yes. So there's a lot of functional tasks. As you can see, most of our therapists will work on different things depending on what the goals are. Yesterday, I had one of my users grasp on to her toothpaste. And we practiced just that, just grasping, opening the lid, which is pretty impressive, right? To have that grasp. Cutting a cucumber, holding onto a bag, grasping your laundry basket and walking with it to get a task done, things like that. So long-term benefits, it's pretty much these: improving range of motion and strength, to decrease your compensatory motions, decreasing tone, if that is an issue, that can definitely be a goal, and to decrease the overuse on the strong side.
Yep. Compensation.
Yep. So these are our therapy recommendations. Again, I won't spend too much time doing this or talking about it, but I will say when you have a therapist scheduled with you with the MyoPro, we will support your therapist and you to make sure y'all are comfortable using the device. We provide guidelines for the therapist because this is a newer device. And even sometimes the therapists are like, well, how do we get creative? What can we do? So we offer guidelines and a program that they can use. But for most part, the idea is to put it on, use it at least 5 times a day, and then therapy to have it 2 times in a week is a really good place to be. And this is a video on the importance of therapy. I don't know. Do we have time?
Congratulations on another
Okay.
step in your MyoPro journey. The MyoPro is an amazing device that helps to regain function in your arm. However, when you first receive your MyoPro, it won't immediately transform your arm. It takes time and effort. It is important that you go to therapy to learn how to use the MyoPro. Your occupational or physical therapist will also establish a home exercise program so you can begin to use your MyoPro brace in your daily routine. Using the MyoPro each day is the key to your long-term success. MyoPro results vary person to person, so it's important that you set realistic expectations with your therapist. And remember, practice makes perfect. If you are currently working with a therapist who is not familiar with the MyoPro, please share your therapist's name and contact information with your regional manager or email us at myocare@myomo.com. Our clinical team will reach out and provide MyoPro training and support. To begin therapy, you will need to obtain a therapy prescription from your doctor. If you don't currently have a therapist, your physician may be able to recommend a rehabilitation center. You may also call your insurance provider to get a list of in-network clinics. Finding an occupational or physical therapist is critical to your success with the MyoPro.
Any questions about that?
So you do support the device through the MyoPro network of therapists, but you also are recommending that you work with your local therapists if you have one, and you're recommending that you do have one if you don't, that you get one.
It is always recommended. Again, it's not a hard and fast rule that you do not get the device if you don't have therapy or therapist, but I've seen best results with someone that has a therapist that's actively involved. And again, we can provide you a list of when you do get a device, we're supportive with who your therapist will be. We have clinical coordinators that are designated for just that, to find you a therapist in the area. But if you have your own therapist and you want to stick to them, we will just train them or offer to train them for free. So yeah, and I'm just going to skim through this. This is more for the therapists when we go over, these slides. Again, building proficiency is one of the things that we talk about when you do get the device. So for example, there will be focus on just attempting to bend and extend. So that's your elbow modes, your single elbow modes. Once you're down to doing that smooth and it's an easy movement, then we will solely focus on the hand, which is opening and close. Again, we need a good, smooth, coordinated movement. This takes practice for some. And then when we're done with our single modes, we kind of combine the two, and it's called multi-joint progression because now you're doing the elbow and the hand together. So here our lady is trying to bend her elbow and close her hand.
As you often do.
Yes. So you kind of have to break it up and then kind of put the pieces together, which doesn't come like that. For some it does, but it takes effort, time, and practice. And that's how you build your proficiency. And then once you've built that, we get into functional tasks and adaptations, stuff like that. Don't know. Just gonna play this video real quick. Yeah, so we're almost done. Oh, this is our lady using
I've got a question, please.
yes.
So I'm stroke survivor living in the UK, and I haven't got insurance. So what are the options for me? Because from what you say, the price seems quite high to pay from out of pocket. So are there any options for people living in the UK like me who need this? Well, to give you perspective, I'm also a medical doctor, so I quite understand the technology behind the device and how it's supposed to assist with recovery of the upper limb. And I think it's a very fantastic piece of equipment, and it would be very invaluable in anyone's stroke recovery. Yeah. So I would desperately love to use something like this to aid my upper limb recovery. But it's just the financial bit that really worries me.
No, absolutely. And I understand exactly what you mean. Outside of the United States, I'm again, it might be something that I have to look into, um, especially because there's no insurance and it's outside of the nation. But I'm still gonna find out. I will get in touch with Myomo and see what or if there's anything we can do. I'll be honest, my mom is a stroke survivor. She's probably watching this right now. She's in India, but unfortunately, there's no coverage, right? No insurance, and it's different. So there's not an option there. But can I get back to you? Can you get in touch with me, Afanga?
Okay, I'll do that.
Yeah.
Okay. And can I beg to leave at this moment?
Oh, yes, absolutely. Yep, you are good.
Okay. Thank you. I'll get in touch with you. What's the best way to get in touch with you, please? Is your
Sure.
email address?
My email address will be linked. I think Ralph is going to do my email and contact. So just feel free to email me and I will get in touch with you.
All right. Thank you.
You're most welcome. All right, we got one more slide. I do want to, yes.
I got to assume that the powers that be at Myomo are working on getting it approved by, was it NH, National Health, in the
NHS.
UK and in India and everywhere else. This is a long process getting approved by the FDA first, and then Medicare. Once Medicare approves it, typically insurance companies, some start to fall in line. Of course, insurance companies are not known for just jumping on the bandwagon. Sometimes you have to fight them to get what you want. But I gotta think that the company's looking at being able to provide this solution in other parts of the world.
I'm sure they already have. I know in Europe, they have their production in Germany. In China, I believe they're working on some Asian countries, but UK, I truly do not know. But I'm going to find out. Um, and you're right, Ralph. At this point, we're just happy that Medicare is covering it. I do not know. Insurance is just one of those sore topics for me, or for I guess for any of us. But yeah, the reimbursements are so it is just that's just protocol that we have to deal with. But I will find out about UK.
More important than that, for like underneath the video, would be if the rental program's still in place, because they did that before Medicare and insurance happened. I don't know if they've dropped it or not, but it makes it a lot more affordable in terms of people who aren't on Medicare or don't have, and their insurance denies them if they've got to go out of pocket. It made it a lot more affordable. Not everybody's got $60,000-$70,000 to plunk down.
Yeah, no, I put that down.
If you get the answer, I'll make sure to put it in there, because that would be a game changer for a lot of people in terms of being able to get it versus not being able to get it.
Right. I also know there was talk about like grants or financial assistance, but I will do that. I will get the information and send it to you, and then you can translate that to our people here. All right, real quick. This is
I didn't have any use of my arms or my legs. And with, like I say, therapy, I've gotten to where I can move my arms just a little bit. I still can't, do anything for myself. I still have to be fed or what, people give me drinks or stuff like that. I can't do anything on my own without help.
Look at him hike that shoulder.
Me, been almost 4 years since my injury, not being able to move and do anything for myself. When I get the MyoPro arm on and can do feed, like I say, feed myself bananas or something like that. I can feed myself and actually get myself something to drink versus having one of my family members come in, whenever I want something to drink.
Okay.
Just to give you an idea of some functional tasks.
I didn't have any use of my.
There. Okay. We do have there's the Myomo. We have a game that's really fun for some of our users. It's a basketball game. So essentially it's just encouraging you to make more reps with whatever, your hand or your elbow. So that's a fun game that we have. Again, not gonna spend too much time talking about this, but if anyone is interested in the MyoPro or knows someone that would benefit from it, just feel free to contact Myomo, contact me, and we can kind of go over these things with you in person. And then again,
I put the clickable link in the promotion and on the YouTube Live, and we'll make sure that it's in the description under the video as well.
absolutely. Yep, and that's pretty much the end of my presentation. But any questions are welcome.
I have a question.
Yes.
Talking about the battery, how long does it last? And, is it specific to the unit or
Yes.
what
this
kind of
is
battery do you have to get?
It is specific to the unit, and it kind of looks like this. And the battery life is usually about 4 to 6 hours, depending, on usage, 4 to 6 hours. And it is a rechargeable battery. So it comes with a little charger that we give you. You just put it in, charge, and I think it takes 2 or 3 hours, and then you're good.
From what I understand, you're not going to run it down during a day unless you do a lot of functional tasks. So, and it said 30 minutes to an hour, 5 times a week. So, unless you're using it an awful lot, you could use it during the day and then recharge it every night and be ready to go again the next day.
Okay.
Yeah. Yes. It's uncommon that it would you'd use it in usually 5 days to a week depending on usage, but
All right. Well, there got to be some questions. Thank you for unsharing, and Dr. Dsouza.
This is fascinating. If it's okay with you, I will. So my neurologist is always the University of Chicago. He knows that I'm in this group and he knows what we have. He's like, anything cool you find out, any cool resources, he goes, please pass them along to me. So I will be sure to pass this on to him. He's always looking for new resources for his patients. And so this has been fascinating.
Thank
It's
you,
amazing.
Carla. Thank you.
Absolutely. It's just amazing. Like, I love to see, especially as it gets lighter, as they become, they become more and more carbon fiber, they get lighter and lighter. And so, because that's pretty heavy. On the one hand, I'm like, well, that could be good weight resistance, but at the same time, at what point does that become counterproductive? So I can't wait to see just so cool. It's just fascinating to see, all these, new devices coming out, or I should say, as these devices continually improve, and hopefully as more research mounts up, they'll become more standard of care, and insurance will, and the cost will continue to drop. So just fascinating. So I really appreciate your time. Fascinating.
Unfortunately, the whole approval process and Medicare and insurance and everything takes way too long.
Oh, yes.
In my
I
opinion,
worked in
takes 17 years in the U.S. from the concept to general availability. I think we ought
before
to.
it becomes standard of, oh yes. I worked in radiation oncology, all the protocols, and and just all the drugs have to work their way through so many trials, however promising they be. And at the beginning, you have to, without research to back it up, Medicare drives what everything else pays for. So if Medicare doesn't like it yet, then nobody else is going to pay for it. That's just the way it works. So you're absolutely right.
I think it's also important to point out that stroke survivors are getting younger and younger. So for me, there's a little bit of frustration here. Right now, we're trying to raise about $20,000 for a young man that had a stroke. He's 15 years old. Even though he's got insurance won't pay for a lot of these new and awesome things that are coming out. And they'll fight it. And I think I mentioned that earlier, just that, there's a lot of, I can see that great benefits from this product, but I can also see the insurance companies fighting that cost and wanting to pay it. They don't even want to pay for proper length of therapy for most. So anyways, I kind of wanted to vent that out there for a minute.
That's a great point too. That's good. Especially like he's so young, like he has so much neuroplasticity. Now is the time to really use the devices and like maximize, he's not done just because he's 15. He has so much growing time. His brain is still growing and it will continue to, like, that would just be just a shame. It's just a shame that he doesn't get this device to get like, get that neuroplasticity in while his brain is still growing, and like build it up now so you don't have to like, continue, so he can be more functional and you're not supporting him for the rest of his life. He can go on and have a functional life.
Well, and I was going to say, and he's also got a lot more life in front of him, like 6 years worth versus somebody like me who's 75. And while neuroplasticity lasts a lifetime, it's important to jump on your recovery as early on as you can get. I mean, in other words, if this young man, whatever you're trying to do for him, Trent, unfortunately, insurance companies and the whole system works against us in terms of time, because while neuroplasticity lasts a lifetime, there is a reason that the doctors will sometimes tell you, you only get better in 6 months, which is a fallacy. But there is something called spontaneous healing that does go on for some period. 6 months is generally used. Of course, it's not like a door slams one day. It's a gradual fade out, fade to black, or fade to no, because it lasts a lifetime. So fade to less, not to black. Sorry, I'm a video guy. We think fade to black. Jumping on your recovery or jumping on any of these devices is really important. And I'm not here to knock Myomo or any devices, but they don't do it for you. They help you do it. And if you want any device, including this one, to work, then you have to work. It's just like all those things with stem cells. People are, think stem cells are going to return them to the day before their stroke. Once they figure it out, and they haven't, you're going to have a bunch of neurons that you can train, but they're not going to be able to make neurons for Ralph Preston at age 58 because I'm now 75. And, so you're going to have, whatever you do with devices, stem cells, anything, there's still some retraining involved to get those connections going.
It's like my favorite quote from Alice in Wonderland. I'm paraphrasing here, but I can't go back to yesterday because I'm not the same person I was yesterday. So like you said, even if you could magically, you haven't had those neurons haven't had the experiences. So they're not going to know what they knew before your stroke. You're still going to have to teach them.
Right. I tell this by saying to people, what if you had a twin? Okay, now it's a year later for your stroke and a year later for your twin. Your twin didn't have a stroke, but they're not going back to the day before your stroke either. Time marches on. We're different people every day. Anyway, so it's important to jump on your recovery. It's important that you do the work.
Keep doing, don't give up, keep going, don't give up. Every day, work on it every day, keep going.
Right.
Yeah, and thank you, Carla, for saying that. And even Trent, just bringing up that I think as therapists and as we're on your side, we're on the same page with insurance. I think it's us against against this thing, but I completely agree with the fact that the more you can do right after the stroke, like that 1 year, that's your main, like that's when you really push, right? So in my mind, I'm almost, while this is for anyone, for like chronic stroke survivors, I also feel like, think about someone that just had an acute stroke and they're putting all their efforts, they're using traditional therapy, they're doing pretty much everything to restore and to regain. That's a good rehab program. That's a dream for a therapist.
Yep. All right. Anybody got any more questions? Let's see if I do. I would usually write down a couple things. Sometimes what I'm doing, Dr. Dsouza, is restating things or making sure that things are clear. Let's see. I believe I saw somewhere that you've had some positive results from people that are even 10 or 20 years out. Is there anything you can say about that? Do you know anything about that?
Yes, that is correct. I kind of want to give you an example without violating any HIPAA. We have patients or users that have not moved. This is going to be a funny example. I have a patient that hasn't moved her hand actively, I think in about 10 or 12 years. The first time we got the device on her, and we had to practice a couple of reps, but she wanted to flick someone off. That's a goal. That was her goal, to flick someone off. So we practiced. And then when she did that, instantly tears, because this is someone that's not had that ability. So 12 years is that's a while, correct? So yeah, to answer your question, yes, chronic.
Okay, now I'm crying. Okay. Happy tears, happy tears.
Happy tears.
Yeah.
One thing I noticed was when you were demonstrating, you grabbed the glass with 2 fingers, not with all 4 fingers. And when I was looking at the video, it looked like the device is dealing with your index and middle fingers and maybe leaving the ring finger and pinky alone for now. I mean,
I don't know if you can see, but well, my device isn't on yet, but this is the graph. So
right.
so it'll allow for this. So it is not all 5 fingers, it is this, right? Now we are
The thumb too.
Yeah, the thumb too. Well, the thumb is kind of static, it's more this.
Okay.
However, like I said, we're working on trying to get these 2 guys also and not leave them behind. Therapists get creative all the time. They will make attachments or whatever, but for now, it is the 3-jaw chuck.
Well, and there are 3 ways to do opposition. One where you move the fingers all the way, one where you move the thumb all the way, and one where you meet them in the middle. The other thing I've found, it's not this, everybody's stroke is different. Some people got the claw and they only can move 1 finger. But I found that the ring and pinky fingers tended to follow what the other ones are doing.
Oh, yeah.
One way to
I'm
get
kind of laughing because I have a friend who's deaf, and so I know a little bit. So this is also the American Sign Language for lobster. So I just when I see that, I'm just thinking, oh, pretend to be your lobster, pretend to be a lobster, and that's what I think of when I see that. So if I'm smiling as you, I'm not laughing at you. I'm like, I see my friend Bridget. I remember her teaching me. This is, we went out to a seafood place. I wanted. She's like lobster. This is and doing this to the waiter, and he's like, "What is she?" I'm like, "Lobster." She's telling me what's a lobster. So sorry about that little sidetrack there, but that's why I'm smiling. I'm not laughing at you, but that's what it reminds me of.
Well, learning to sign again with both
Did
hands.
she say Medicare covers this whole thing? Is that what I
Bigger
just
goal
saw?
with- Good,
Yeah.
I'm sorry. Go ahead, Rich.
I'm sorry, Ralph.
That's okay.
I thought I saw a post that said Medicare covers this 100%.
Yes.
Now, does Medicare need a referral from a neurologist or from a therapist?
Yes. Good question. Yes, they do. And once the screening process starts, Myomo is pretty good with getting in touch with your PCP, your physician, but yes, you do need a referral from your doctor, and your therapist. There has to be a therapist prescription.
It has to be a therapist. Okay.
Everything.
So are you in California?
So I'm based out of Florida, but we have specialists all across the country. So whichever state you're
Okay.
in, yeah, just tell us and I'll
Yeah.
put you on to whoever can assist.
Rich, if you
Okay.
if you reach out to Dr. D'Souza, then she will connect you with an appropriate colleague in California. I would have to.
Oh, I have a couple of yeah, that would be good because I have several neurologists I work with at UCSF. And all I gotta do is call them up and go, "Hey, refer me to this." And that's the way I do it because that's all doctors are good for now, giving you a referral.
Well,
Sorry about that.
Medicare
Sorry.
doesn't do anything without a referral. By the way,
Yeah, right.
when Medicare, like most insurance, resets every January, and you get back into therapy if Medicare is paying for it, but they're going to require a new doctor's
Right.
referral, even
Everything's
if you had
new.
one for the year before.
Yeah,
It's their way of making sure that you need what they're about to pay for.
sure. I get that.
Yep.
One quick question that before I forget, lose my train of thought. Excellent presentation. But I have a question. When like I said, I suffered a massive stroke when I was just 23. I'm 53 now. When I had a major issue with that, I looked at the design of your sleeve. I had a problem like one side was more weaker, so how will you compensate for the other side or your total body movement? Or you're going to get stuck on just that one side, but to strengthen the other side, you have to build both sides. What I had to do, like when Trent was talking about with younger stroke survivors, I was just 23. So I had to learn how to basically rehab myself through this process. So now, like I said, it's been 30 years for me, but I still have to move both sides. Instead of having just one side weakness, how do you compensate with that glove to say, okay, let's balance everything out? Because right now, I still have balance issues.
Well,
How would that glove kind of access that to help me through that process of healing?
I'm not the doctor of physical therapy, and I'll let her talk in just a second. My quick answer to that would be by doing bilateral therapy exercises and by doing functional therapy bilaterally, things like picking up the laundry
Yeah,
basket and things like that. I think it's real important to,
absolutely.
like when you do marching
Mhm. Yeah.
and things, to just go ahead and do both sides. so that you, because I'm a big believer in symmetry, and
Yes.
and
Yeah.
symmetry is real important, especially if you want to, like, stand up again perfectly with that magic string coming out of your head pulling you up. I
Yeah.
actually did I did what I called neutral. I found out after I started taking yoga, it's called mountain pose. I just literally place my feet, my ankles, my knees, my hips, my uh, chest, my shoulders, and the magic string, and stood there. I had my hands at my side. I learned if you flip them out, it's called mountain pose. I
Yeah.
also did a lot of symmetry
Yeah.
exercises.
And
Um,
that really helped me also with, like I said, I did a lot of chair yoga, Tai Chi that
mhm.
really balanced me out, that because it was just like my first 3 to 5 years, it was just, I was like leaning, you know. So how did I balance it? Like I said, just constantly, consistently walking and, putting things together now, So, and like I said, after 30 years now,
Well,
I feel with confidence. Yeah, but
in both yoga and Tai Chi, symmetry or balance and doing
yeah,
things on both sides are important. And so
yeah,
if you're not engaged in those, the very least you could uh, make your home program work with Myomo, work with your therapist
mhm,
to do things that are bilateral so that you're strengthening both sides.
right,
Remember, there's coordination stuff too. You got this
yeah,
arm that doesn't work, all of a sudden it's working. You got to learn how to make it work with the other things like
yeah,
handing things off.
yeah,
And so, and by the way, functional therapy is one of the
mhm,
best therapies you
absolutely.
can do because you have to live, and
Mhm,
therefore you have to cut up cucumbers and flip people off
mhm.
and all the things that we do in carry the laundry, all the
Yeah,
things that we do in daily life, and the more you
yeah,
can engage in them, the better. It's just a great way to
yeah.
get in more therapy time. And
Absolutely, because like you were just discussing functional therapy. The best thing that ever really helped me, my mother always made me wash the dishes with plastic cups, reaching and bending and everything like that, even when I couldn't really grasp the thing, but consistency helped me just do all of that. You know, I think, with that, her whole thing was like, you gotta be independent. That mom was not gonna be here all the rest of her life. So she made sure that I can be able to be functional or independent on my own. So that type of situation, like I said, that type of therapy is consistency of everything. That's even like with working out. You can't say, well, I'm gonna just work out for 90 days, hit that goal. I still work out to the day after 30 years. you know?
strokes a
Hey,
lifetime.
Demont,
Yeah.
where you located?
I actually right now, my wife and I, we are full-time RVers. So actually
Oh,
we're in
you're a
Hudson.
traveling man.
Yes, we've been full-time RVers for like what 5 to 6 years now. I'm from Michigan, from Detroit, Michigan. But I am in actually now I'm in Hudson, Florida now. We just left the Bahamas a couple of days
Still
ago
my
for a
hands.
cruise.
Sorry.
Yes, yes. So that's where I am now, right now.
Well, you're very inspirational
Rich,
because if you,
that's why I laughed when you said where you located, because I knew he's a full-time RVer.
oh, so, having a stroke when you're 23, your brain's still developing. And of course, having the support of a mother like that who won't take bullshit from you, she probably accepted it before you did.
Well, yeah, I found washing dishes real, I did a lot of that. I did something that doesn't have anything to do with the Olympics, but I started something what I called, for some unknown reason, left-hand Olympics. I started doing things like opening jars. And then before my stroke, we don't have a map as to how we used to do things. It's all automatic. The brain just does it. It doesn't remember. There's no like memory, like you remember when the first time you went out with your wife. There's no memory for how you open a jar. So I probably held it with my left hand and opened it with my dominant hand, but I just switched around, did everything possible. I mean, dishwashing was real good. Hopefully, she taught you how to do laundry and cooking too, but that's another subject. I did practice with, I got out the plastic picnic set and practiced washing dishes with those before I washed the good china, because like I said, one of the biggest issues in stroke recovery is grip, knowing how much you're gripping, not some. I practiced carrying the mail back with the mail down, held down in my hand. So if I released my grip at all, the mail would fall, and it did fall every other day for a month or two until I learned how much you have to know, how much to squeeze, that you're still squeezing, and that you're not letting go, and eventually doing something as simple as going out and getting the mail. And the way I carried it inside of a month or two, I was able to gauge. Of course, another thing, and I practice this a bunch, is like letting go of stuff. Of course, if
I can't let go.
wasn't a problem, Sabo wouldn't have a business. Because the Sabo Flex, the original Sabo Flex, is kind of all about learning how to let go. So
yeah, it's a good thing I have a grip. I don't have a release. See, that's what I see. My thing with the neurology world is, if I can do this, if I can do that, I want to know what's going on in my brain to make me do that little movement. So I'm always asking for MRIs or fMRIs, and they're always saying it's not going to help you any. And I would say to the doctor, why not? Knowledge is power, and the more I understand about my brain, the more motivated I become.
well, two things. MRI is going to show you the status of your brain, not the. I don't think they've got any way to. Well, yeah, they can do connections, but it's not. In the studies I videoed, they typically got some kind of skull cap with 70 or 80
Yeah,
sensors
like an
on
EEG.
it, and they can measure brain activity when you're doing functional tests and stuff, and something like that would tell you a lot more about whether firing is going on and connections are being made, because you could do a test 1 month and then go back another time. The other thing is
Yeah.
MRIs and things are expensive, and you're fighting the insurance company thing again.
Yep.
Because doctors aren't going to prescribe them if, number one, they can't justify them, and number two, and if insurance has to pay for it. If it's anywhere out in left field, insurance is going to deny
Well,
it. So
I just finished an EEG for 2 days, and it all came back normal because the doctors think that I might have an epilepsy seizure, little tiny ones, and it came back negative. But I kept a log of everything I did with timestamps. So I'm waiting to see if they'll go through what my brain is doing when I got up, when I went into the other room, when I rode my little tricycle. Well, it's a big tricycle, but I got my hands on a tricycle. So now I take a strap and I strap my hand onto the bar and I ride around. And basically, to me, therapy is your life is therapy. People ask me, what kind of therapy do you do? I go, well, I do therapy 24/7, 365. I mean, I have to think about getting up. I don't just get up. I have to go, oh, I'm going to get up now. So to convey that to people is a challenge sometimes, but that's what I tell them.
Yeah.
and we all know that. Our therapy is every second of that we're breathing.
Absolutely. Rich, I totally understand. You know, I always think, you know, the brain is a powerful tool. You
Yeah.
know, once you utilize it as a tool, you know, because, you know, if you have a negative thought to say, I
Yep.
can't do something, that brain is just like, okay, I really
Okay,
can't.
you can't do it.
Yeah.
Okay.
So,
It
so
agrees
what
with
kind,
everything you, it agrees with everything you
yeah,
say or think.
absolutely. Because what kind of motivated me, I had a, like I said, I had a counselor at Mission Rehab that said I had the mind of a 2-year-old. So go figure. So
Yeah,
that
well,
really motivated me. And like I said, I had an excellent support system. You know,
it
that
sounds like, yeah.
even now, like I said, with our communities around here, that you can motivate someone else. And we work together as teams, you know, instead of just like, okay, just let me think about myself. No, let's help each other. You know, I
Yeah.
think this is one of the major problems with this recovery process in our communities and stuff. Let's work together and help each other. And like I said, it's all about helping and providing hope for people, you know.
Yeah,
So, and to show
absolutely.
people that, okay, if Demont can do it, Rob can do it, Rich can do it, Trent
Yep.
can do it, you know, we can all do it. So that's the
Amen.
way, you know,
Amen.
that's the way I look at this whole situation that we're in right now. You know, we can't
Preach.
allow this 87% of these people just say, I can't do this. No. So you have to really be motivated and, you know, like I
Yeah.
said, and be dedicated. You know, even like I said, groups like Ralph's groups and other groups that we have that's out here, we have to be consistent on a daily
That's it.
basis. You
Rich,
can't just be
Yes.
stuck. But
Yes.
Rich, I have a suggestion for you. Since you're
Mhm.
connected to the University of California, San Francisco, and a bunch of neurologists, and that would be to look for a study and get involved in studies that's sort of free physical therapy, if you will.
Yeah.
University of South Carolina in Charleston, near where I live, has something called the Stroke Recovery Research Center. It was unique. There may be other ones around the country now. When they started it 10 years ago, and it's under a grant, NHS grant. And what they do is they study the effectiveness of different types of therapies in triple blind studies. So that's where I saw those, I videoed those skull caps and things they were tied to.
Well, I just finished one.
Okay,
Um,
never
the
mind.
KMS.
Or anybody
Yeah.
else out there, look for studies
Yeah.
at your
You want to
local
be part of it.
hospital.
You want to be part of a trial, and then
Well,
you kind of get in free. Hey, I'll donate my brain. If I go out early, you can take the brain with you. All right?
Jill Bolte Taylor is doing it, and
Yeah.
she,
Oh, I just saw her. She was just did a pot. She just did an interview on YouTube with that 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 guy Steven. I think he's Diary of a CEO.
okay.
He just interviewed her. Oh God, I'm telling you, 2.5 hours for Jill, and
She's
it's
back out on the
fantastic.
circuit. She's back out on the circuit again because she has a new
Yeah.
book.
Well,
I
that's usually what gets you on the show, right? She needs to go on Colbert and Kimmel now.
I need to contact her. I actually have her private email, and she agreed to come on some Tuesday. I need
Oh,
to read.
that'd be
I need to read
fantastic.
her. I need to read her new book before I have somebody like that on and try and talk intelligently with her. Um,
Oh, I think it's like what Damon said, man. It's all about not giving up. It's all about having that demonstrating
yeah,
that you have hope for others. Because who else? I mean, that's the only purpose I can think I have in life right now is to help others. I mean, I was a firefighter and an EMT and a musician, so I lost a lot. You
Yeah.
know, so what's the point? And I suffer from this thing called pseudo bulbar effect. Anybody heard of that one?
Oh, sure. I had it.
Yeah,
I had it slightly. It's where, for those
yeah.
who don't know, it's where you laugh at things. You find yourself being the only one who's laughing at something you
Or
might have said,
crying.
or crying inappropriately.
Yeah,
It happens to about 30% of stroke survivors. I think it's more than that. That's what the statistics say. About 30% Parkinson's. I'm not sure about MS, but definitely Parkinson's and stroke.
yeah. And my stroke was in the basal ganglia.
Yeah.
Anybody know that one?
Oh,
Yeah.
yeah. All the stuff in the back of your head's worse than the strokes in the front of your head. That's a gross generalization, but it's true.
Yeah, I understand.
Because all the
Or
things
on
in
this,
the back put together, all the pieces, all the other pieces, thalamus processes, cerebellum connects the two sides, send it out the brainstem, which converts it to
right.
signals that your muscles can deal with. And here I go talking neuroscience in front
That's
of
right. I
Dr.
love neuroscience. I was always into it because my mom died from a brain tumor, and my wife had a brain tumor in 2006, and UCSF saved her life. So before my stroke, I was always into the brain. I never really understood why there's no major focus on the brain like there should be. Like it's always the last thing you look at. We're
Uh,
always trying to,
there's more focus if you than you might think if you look around. Especially these days, it seems like it's amped up recently, but that's just a anecdotal observation on my part.
yeah.
I knew a little bit about the brain. I knew I
Good
had
you,
a
Trent.
stroke, but I've kind of haven't gone back to school or anything. But I've been kind of studying the brain ever since I had my stroke because I'm like you, Rich. I'm a sponge for knowledge, and I have to
Yeah.
understand everything. If you won't, if I told my therapist, show me because I'm a visual learner. You have to explain it
Yeah.
to me because if I don't understand how it's going to fit into my program and my life, then I'm not as likely to do it. So
Yeah.
that's why I suggested studies because they're an ongoing way of not only learning about your brain, but learning about how brains work by
Yeah.
participating in the study.
Yeah.
All right, well, we've been
Well,
talking all around this subject, and it's a great conversation, but I don't know how long Dr. D'Souza has. But I've been stepping on her with all the neuroscience and PT stuff, and so anybody got any more questions?
well, now that I know about Medicare, I'm gonna definitely send an email to my neurologist
So,
and say,
yeah,
yeah,
Richard, just based off, can you get in touch with me? I put out my email
yes,
because
I can.
just based off what you've said, I feel like, yeah, we can help you out. If you want to get in touch with me and we can talk.
Okay, I will. I'll send you an email and we'll connect. That'd
Cool.
be great.
Absolutely. And again, Ralph, thank you so much for letting me come over and speak. I do feel like y'all, this is an amazing group. Just this support, the information y'all have, this is refreshing to see as a therapist. I'm just going back to, wow, I wish my current patients have, I kind of want to recommend this because the engagement, just exercises like you're sharing little things like, by manual tasks, bilateral crossing midline, opposition, just little things like that go a long way. So I love that you have this to support
Well,
stroke
thank
survivors.
you for taking the time, and there's some of us
Thank
stroke
you, Athena.
survivors that know a lot more than you might think.
Yeah.
Basically, one of my philosophies, and I think it's probably a shared philosophy in this community, is if they don't give us what we need, we'll figure it out for ourselves because we're left no choice. No, it's true.
Absolutely.
True.
And so a lot of us, like Rich and Demont and Wendy, everybody in here, I put on these meetings because I figure that everybody here is there for one purpose and one purpose only, and that is, what can I learn that's useful to me in my recovery? So that's the focus here. And
Yeah.
we had 22 people in here. That's pretty good. Don't forget that some of these videos get hundreds, a couple have gotten thousands. So there's a big audience yet to see this out on YouTube. And for all those people here and in YouTube land, one more time, I will say all of Dr. Dsouza's contact information, answers to questions, links to videos, the link to contact her, her email, her phone number, all be in the description under the video. It's right under the title. It says, like, it used to be bigger so you could read more of it, and now it's only like 10 words and
Hey.
says you have to click more, and then
You gotta get one of these, see?
you get to,
There
well,
you go.
if you click more, you'll get my big long description. I put everything in the description. We're even putting like clickable links to various key points in the presentation now, using some AI to generate those, because it used to be a real painstaking task. Anyway, so thanks to everybody for coming, and thank you,
Nice
Dr.
meeting you, Damon, Winfred, Athena,
Hi.
Ralph.
Absolutely. Thank you,
Wait,
guys.
Someday we'll
Anthea, let me ask you one question.
Okay.
In the future, is it anything doing for the leg?
That's a good question. Not with Myomo, but I would be there's a bunch of stuff out there that's coming out with other devices. So I would look into that if lower limb is your focus. But yeah, unfortunately, Myomo is just the sole focus is the upper limb, but I know there's a bunch of really good stuff out there for lower limb.
Okay, thank you.
You're welcome.
Bye,
All
everybody.
right, guys. Bye, everyone. Have a good one.
Winnie, that would be like